Good afternoon, everybody. There we go. Can you hear me a bit better there?
Yeah.
Wonderful. Okay. My name is Donna Miller. I'm the Director of Policy Engagement and Development at an organisation called BHA for Equality. BHA is a health equality charity with a 35-year history of engaging with disadvantaged and marginalised communities. So everything that we actually deliver is with communities who are less likely to take up health services, and that includes point-of-care testing and also screening. And most of the localities that we actually work in do actually have residents, are actually classified as being areas of deprivation. Now, our community engagement approach follows what we call NICE guidelines. I don't know if any of you have actually heard of those. So NICE guidelines are effectively a framework that is for local authorities and health bodies to enable them to actually improve health and also tackle inequity in the provision of those services. And it also aims to support those bodies to actually empower local people to be involved in design and delivery. So we're very keen in focusing on that particular framework in whatever we deliver. I think a starting point for us is to ensure that we actually have a staff team that reflects the communities that we actually engage with. So we actually have a staff team with a good representation of communities across Greater Manchester. And that staff team also have a range of languages to be able to engage with those communities across Greater Manchester. And we think that is one of the key successes in the work that we deliver. We develop working relationships and partnerships with local community organisations, community activists, residents, local community centres. We go to key meeting places and places of worship. And our work is very, very similar to our partner, Khan, and also Winning Hearts and Minds. So point of care testing is not new to us. As over the past 13 years, we've led delivery of what we call Greater Manchester PASH. PASH means passionate about sexual health. And it's a partnership with two other voluntary organisations that focus on HIV and sexual health. And it's taken us a hell of a long time to actually get to the stage where we, have actually started testing, because we've had some resistance to it from various clinicians, but we got there eventually, and we're very active in the community now. So that's all about sexual health testing and prevention activities for high-risk groups, as well as support for people who are living with HIV. Our involvement in this programme was therefore an ideal opportunity to develop on our existing testing and also to collaborate with our partners. The start of this programme, however, was actually quite unique. Unique in the sense that we were involved from the beginning, not at the point where the ideas were already established, and not at the point where, funding had already been obtained, which is usually the case, but before the bids were actually even drafted. So that gave us the opportunity to outline the different approaches that we've adopted in our other community health programmes, whether it be tackling low uptake of cancer screening, whether it be encouraging screening for TB by new arrivals in the country, or even encouraging black men to go for a PSA test to identify risk of prostate cancer, because those are just a few of the things that we actually do. So we actually had a lot of learning to share, and we recognise also that different communities need different approaches. So from our experience, we know that a key to successful engagement is a diverse workforce. And it's a workforce that actually understands such things as culture, language, diet, and religious observance of different communities. And that is embedded into our staff team. Our work on CVD has actually developed, as was mentioned before, from delivering blood pressure checks right through to now point of care testing. And as was mentioned, we're leading a specific piece of work in North Manchester. The service has actually been very, very well received when delivered in the community. And our approaches, and again, I remind you, I talked earlier about the NICE guidelines. So our approaches actually involve, first of all, promoting our services at community events. So we've been to community events like the Caribbean Carnival, like the Asian Mellow. We link into things like English classes at colleges. We visited community centres and community group meetings to talk about the programme and explain what it was about. We also took the machines as well so people could see what the machines look like and get an idea of the tests. We engaged with workplaces such as housing associations and their tenants. We also linked into champions who are within supermarkets to actually help them to promote the services that we delivered. We linked in with schools to engage with parents and grandparents. And we also collaborated, it was mentioned earlier, about primary care. We collaborated with primary care. Primary care networks, that's GPs, groups of GPs. They do also carry out NHS checks. But what we find is that not many people are prepared to approach, to go to their GPs for those tests. So what we decided to do, we would partner up with some of those primary care networks and work with them. And in a couple of instances, we actually got the GPs to send out texts to their patients who were eligible for health checks and invite them to a community event. And they found us there carrying out those tests. And they were very, very well received. We also engaged with places of worship, churches, mosques, temples, and the final thing was that we ensured that the resources that we all use were culturally relevant to the communities that we engage with. That doesn't necessarily mean that they're all translated, but that they're in plain English, in very simple English, moving away from, clinical terminology, for example. I think I've missed one of the slides there, actually. Just bear with me 1 second. Sorry. I can't talk and press this at the same time. Now, community partnerships are also a key to success. So one of our most successful engagement activities was delivered at Manchester's British Muslim Heritage Centre, where hundreds of Muslims actually attend for Friday prayers. Our relationship with the centre resulted in us hosting an open day to talk about the testing that we deliver. And that actually led us to delivering point of care testing following Friday prayers for over a month. And we actually had people waiting for us to come and actually carry out those tests. They were willingly waiting for us, which was excellent. Many preferred this approach of us actually doing the tests at the centre to going to a GP. But the fact that our staff were fluent in Urdu, I think, also helped. We know that our activities are successful. One individual actually came over to us. This was after he'd been tested. And he actually said, if it wasn't for coming to you to have the NHS check, I wouldn't have known how unwell I was. I understand now why hypertension is known as a silent killer. I think this comment actually shows the impact of our work. This particular person was immediately put on medication by their GP. So I think that in itself shows the impact of our work. It's important to acknowledge that people we engage with are concerned about their health, but there are other factors that sometimes take priority, such as managing as a one-parent family, as your partner died during the pandemic. Individuals are still suffering as a result of the pandemic. Working long hours to keep a roof over your head, even though long hours increases your stress, increases your risk of hypertension. So it's about understanding where people are at in their lives and bearing in mind that when offering such services in the community, we have to look at ways to encourage, to make participation easy and also accessible, and also using engagement approaches that encourage behaviour change. And I think all of this that I've said, oh, sorry, wrong slide. I didn't even realise that. All of this that I've said leads to provision of an equitable service which increases uptake to those individuals that are sometimes called underserved. And please excuse the fact that I can't use this. Thank you very much.
Good afternoon. My name is Schola Dube. I'm from the Caribbean and African Health Network. As you have heard the introduction earlier on, so I'm the Deputy Head of Delivery of Services and Clinical Lead. And I'm proud for us to present in this because I'm able to put myself in different slots. First, as somebody who's been looking after the community while in the health setting, like the acute setting in the NHS, and then coming out here, it kind of like empowers me because then you can relate to what people are saying. So having heard what Nana presented, thank you in the introduction, and Khan realized there was a problem. So our mission is to end the health inequalities and wider disparities for the Caribbean and African health people in generation. As we go through, we'll show you how we intend to do that. And just to say, when this project came, the Lipid project, it was great for us because from 2017, when Khan started, we had identified that there was a problem with cardiovascular problem in our community. A lot of people were dying and, nobody was like picking up why. Or maybe, as you heard earlier on from the Rachel, maybe we were not naming it. We were not identifying why are people not coming until the end. And we had to come and identify this risk. We highlighted it at first, like what you heard my colleague say, so maybe people weren't listening. Or even when they listened, they didn't know why this was important for us. So our vision in Khan is that the society will embed racial equity in policy and practice, ensuring that the strategic operational actions of service providers across the health and cross-sector agencies and commissioners lead to racial and social justice for Black people. We've done that in the journey by co-producing resources that are culturally appropriate, breaking down the language to what people can understand, because people say there is information, there's resources, but when you talk to the community, they don't know about the resources. They've never heard about the resources, or the service providers aren't breaking it down to the language that people understand. So as I go through, I will explain to you why. Sorry. So our approach in Khan, as you heard my colleagues say, or the other partners, we work collaboratively with the community structures and systems. We get into spaces where we are discussing what the issues are. So during this Lipid project, we're able to work, like you had BHA and Winning Hearts. We sat together and reported back and shared notes. What were the learnings? We didn't wait till the end of the project to come back and say this. As we found issues, for example, the policies, we impacted on the policies because people were being screened at, you have to be above 40 or 50 before, they check for you, the NHS checks. And we went out in the community and found out people are pregnant in their 20s. Maybe people get preeclampsia and they are treated. But then what we need to remember is that this comes back. So if somebody's had a baby at 24 and they had preeclampsia and they were treated, if they're going to wait until they're 50, what happens during that gap? So we had to address that. And during our training, our sessions of checking, we found a lot of people who were below the age of 30 or 40, and a few under 30, presenting with high blood pressure and high cholesterol. We had to come back on the table and say, look, this is what we are finding out there. If we are limiting this, what are we going to do with the people that are suffering? Are we waiting for them to present when they're acutely ill, or just before, they die? Because obviously people have died from this. And this had to be adjusted to ensure that people are not being left out, because it was identified that in our communities, a lot of people are presenting at very early stages. So we worked, with the champions to promote the work and assets of the community, because we realized that people wanted to see, firstly, obviously, people who look like them, people who understood what they were talking about. A good example, people will go to the GP and be told, go and change your diet. What does that look like? You say, for me to lose my weight, I must change what I'm eating. But they didn't understand what people were eating or how people were, and people were communicating themselves. And it also came to the point where we had to build and foster cross-sector partnerships. So in that partnership, we found that sometimes, because of the languages that people spoke and the different cultures, we needed to be in the same space with people who can actually present the information so that it's spread across. And what we do in Khan, we've got continuous engagement to provide solutions and bridge into the community. So if you're looking at, so how we do this, we lead. by leading this, we go into the community, and we've been leading in some projects. We've been leading, for example, some of you may be aware, we get our doctors who look like us or pharmacists to present on Saturdays. We've got the health hour. People are able to come in on Zoom, ask the questions, present what are the issues. In that session, they're also educating people about what can you do differently? How do you present your problems when you go to the health providers? Because people go to the GP and sometimes don't know how to present themselves, but then you find that they walk away without achieving anything. And then we are also educating our service providers to say, this is what people say. This is how they don't understand your prescription, for example. We found out when we went out there, a lot of people had medication, but didn't understand how it works and the side effects. So Mr. Jones goes home, takes tablets, gets side effects and thinks, I don't feel right, and puts it away. So we had to educate people to say, look, if you have a reaction or side effects, this is what you expect, and this is how you address that. So we've got a lot of support in there. Like I said, we've got nurses who are volunteering to support sessions. We've got doctors who sometimes may actually speak to people about conditions that people are afraid to talk about, because there's also issues with the cultural issues and race, where people need to feel safe that if they're speaking to somebody, they will not be judged. And there was also a group of people, for example, some people with migraines, maybe who are not in the system, who need somebody to talk to them about directing them where they can get help. Because ultimately, we hear in NHS, everybody's talking about money. There's no money for this. So if we are not supporting these people, by the time they get to the system, it costs more to support a patient who is acutely ill. How much does it cost for an ICU bed, high dependency bed? Whereas if people got support in community, it means we are saving the stage of acute illness. So in Khan, we also provide advocacy, and we advocate for patients. There's an advocacy service. As you heard earlier on, when people go to the GP, it's a 10 minutes appointment with one problem and okay, bye. But when they came to us, we found out a lot of issues, because as we know, we saw an earlier report that a lot of these people are from poor backgrounds. They're underserved. It's more of the problems around lacking money, they had to work harder. To them, the priority is probably going to work before they look at their health. So we try to advocate and direct them to right places. And by giving them this knowledge, we also enhance the fact that they realize that their health is a priority and where to get help. So why CAN for the community? Caribbean African Health Network had identified, like I said, in 2017, before this project came, we were doing every weekend nurses were going to churches, community places to do some checks, because we realized that the problem is there is poor access and experience for our communities. As mentioned earlier on, that the issue was with the structural racism and the systemic discrimination. So you notice that at the beginning of this project, things were addressed as they were, that we needed to eliminate that. And then because of the problem of this racism, it meant that people did not trust the system. So if they don't trust this, they don't access the services. So the reason why they didn't trust the system, there was lack of targeted research. A lot of decisions were being made for people, a lot of choices being made for them, and people felt that they weren't safe. So ultimately, the engagement was poor. So our response to that, as you see from CAN, we have 6 health streams. And as you can see, cardiovascular is being the first step that we've put here, because most of these problems, they are the center part of hypertension, the cardiovascular problems. Somebody's got poor experience with maternity. Someone's got mental health. They'll get stress. So ultimately, cardiovascular was the main thing where CAN established the health checks, which we as nurses started to go out the community. So basically, coming from there, how we did that is doing the health programs. I've already mentioned one that we do on Saturdays, but we do quite a number we did a lot of other other sessions where people were invited for tests. We go to spaces where people feel they can trust, like, you've heard about the Windrush, we go to people's churches. We have been invited almost every weekend to come to places to do screening. We found out during this lipid test, at a certain point, we were just being invited to come. We got to a point where we said the program is over because there was high need and there was a good response from people that got tested. So in all this, where CAN becomes effective is we're involved in decision-making and representation. You may be aware that we have influenced the APPG, making sure that the decisions that are brought there, they represent the people. Our strength is that previously we were part of the sounding board, so we got the voices of the people. So we're able to bring up to the table, this is what people say and how people felt. And we're involved in the benchmarking to majority of populations. So CAN has got a representation amongst our communities, because you can have 10 Black women here or 10 Black men. They're not from the same backgrounds. They're from different backgrounds. So it's really important that we understand where they come from. And obviously, looking at the structural racism, CAN is making sure that racial discrimination and unconscious bias and conscious bias is tackled. We do that by providing cultural appropriate sessions so that people have got cultural humility. We do know that no one can be cultural competent because of the number of cultures, but there's cultural humility. So basically, this then improves the community engagement. I'll just come over. Sorry. So, I think because the other slides went there before, the photos are at the end. So what you'll notice at the end of the slide, there's photographs of that we took of where we were engaging with people in their safe spaces. So people came into the space. For example, our biggest centers were the SO classes. Green Haze was our home. When we went there, people were calling their families who were not part of the students to come in because they saw the results. One of the things we saw is that a lot of people couldn't speak the language, but we were able to communicate with them with resources that some people were visual. In our communities, we found that people are not always good at speaking about themselves. So if someone can't communicate about themselves, they can't tell you how they feel. A gentleman who had needle phobia was assisted by other people, said, I've had my test taken, come, it's not as bad. So that was a sign that we assume that anyone can just walk in. And then some people could not afford, as we already spoke about, people from poor communities. So we had BP machines when we found people walking around with a blood pressure. As you all know, we expect someone to have like 140 over 60, people walking like 220 as a systolic, over 190, people were very unwell but didn't realize that they were needing some help. So what we did was, first we did the test, then we gave them the machines and we taught them how to use the machines and then referred them to the GP so they had the ability to test themselves. People couldn't speak English. We were able to demonstrate so they could actually see how they could use the machines. And I think what was really sad is that some people we referred to the GP, they couldn't go to the GP because it was a priority for them to go to work because they were providers for their families. So coming back to the table, when we reported this, what we found is there was more need for people to be seen in their spaces because, like, we found out bus drivers, if we identified that they had a problem, they couldn't report to their work because it meant that they can't work again. So we had to bring such issues to say, what is important, a person's life or their job? But we know that they need their job. So what we found with this project was, it's a shame that we raised an alarm and people got excited, and then we got to a point where we're like, sorry, we can't do this anymore. You need to go back. But obviously we've not stopped there. We continue checking people's blood pressures, educating them about healthy eating, also educating our partners about removing the barriers, because it's okay talking about equity, but and equality, but some of those barriers is, what do people do next and who can support them? Thank you.
Right, hi everyone. My name's Nick. I'm the lead for the community-led initiatives work stream of Winning Hearts and Minds. Just before I start, I want to say a big thank you to everyone that's been involved with this project. It's a collaboration between 5, 6, 7 different organisations between public sector and VCFSE sector, and these sort of things don't just sort of happen out of nowhere. It is those relationships and building trust between each other and learning about each other that really sort of enables us to do this great work. And yeah, I want to say thank you to Schola and Donna as well for setting this up so well. I think a lot of the things you talk on, I'm going to build on in what I say as well. But it's so strong. Some of the things you said, it's wonderful. So yeah, a little bit just setting the scene about Winning Hearts and Minds and the community-led initiatives work stream. So we've been working in North Manchester specifically since 2019. We've recruited field workers from North Manchester, so they have that local understanding of context. And my team works to empower people who live in North Manchester to feel able to live healthy lives in an area where our city's health inequalities are felt most sharply. And yeah, that can look like helping people access what's already out there, helping people set up community groups, helping smaller community groups to become more sustainable, and helping larger community groups to keep doing the work that they do. But it's also about reflecting back what we see and what we hear from communities back to the system. So helping our council and our health service better understand how they can work in North Manchester and how they can work best with communities in North Manchester and help address some of those barriers that North Manchester residents often face. So almost all of our work is about listening. It's about building trust, growing relationships, and making meaningful connections. So what was our involvement in this pilot? So firstly, we needed somewhere to work from. So somewhere specifically that we could store the testing equipment for as little cost as possible. And yeah, we have office based in North Manchester, but actually sort of moving into this sort of a little bit more clinical side of things. We've not really done this before, so we needed that base that we could do some of that stuff from. Secondly, we needed to offer the health checks in places where North Manchester residents feel comfortable, and particularly for people who might not feel comfortable in traditional clinical settings. And thirdly, we needed to come alongside residents. Firstly, to encourage residents to take up the testing offer, but secondly, to help empower them to follow up on that. So I'm hoping you can see that what we offer from Winning Hearts and Minds and what kind of BHA offer as well is really embedded, sort of the work that we already do. This sort of offer is really embedded within that. And we know that we really would have struggled to do any of these aspects of the project without our existing strong relationships and knowledge of North Manchester. And building those relationships and that knowledge takes time and effort. Involving and commissioning community organisations like CAN, like BHA, like Winning Hearts and Minds, and like so many others with that deep understanding of local communities adds real significant value to what we can offer in community testing. So moving on to our key learning. There we go. So if you take anything away from what I say today, I want it to be these 3 points here. So firstly, the logistics are really important. So if you're a service who's delivering point of care testing, there's lots of sort of little bits of logistics that are really important to think about. So first of all, as I say, you'll need existing knowledge of the area or the communities that you're working with. And then talking about those real specific bits of logistics. Base needs a medical fridge, it needs ambient storage, you need somewhere for the cartridges to be delivered, and specifically that was a particular challenge because those cartridges need to be immediately put into a fridge, and of course deliveries don't come in a 1 hour window that's nice and convenient to do that. It's sort of like, oh yeah, it'll be Tuesday, Wednesday-ish. Yeah, you need sufficient machines to be able to process sufficient tests in communities. The machines need regular maintenance, calibration. They need to be operated within a regular temperature range, et cetera, et cetera, et cetera. But I guess more interestingly within that, doing these tests takes time, and people receiving tests are often sat waiting before, during, and possibly after their tests. and they're sat in a community centre, often where they feel comfortable having these conversations. And that's a real opportunity for us. Someone from whatever demographic that we're targeting, that as a system we may well struggle to engage with, is engaging with us. And they have free time, and we're with them. So how can we make use of that? And I'll come to a bit more of that in my third point here. So number 2 is that residents really do care about their health. Now, often we'll be doing testing such as this in areas where health outcomes are poorer and where statistics look quite bleak. And I know I've heard people say from the system in the past that people don't care about their health here. But what we saw throughout this testing, even if you test someone and their blood pressure's through the roof, or their Q risk is very high, the people are not apathetic. People do care, but often they're scared, or they don't trust their GP surgery, or they've had bad experiences in the past, or their loved ones have had bad experiences in the past, or they've experienced racism, often through institutional discrimination, covert microaggressions, internalized stereotyping. People do care about their health, but for one reason or other, they don't feel able to address the issue, or don't feel that approaching services would make any difference anyway. So that brings me on to point 3. People with poor health outcomes who aren't engaging with the system in the way that we would like them to are doing so for a reason. And there is always a reason. People face barriers to accessing help, and we need to be honest with that. We didn't come across a single instance during this of that reason being malice, laziness, apathy, anything like that. It's our job as professionals to ensure that when we have an opportunity to engage with someone, that we do so meaningfully, and that we listen with empathy. We ensure staff are given time and space to listen with empathy, and that they're able to get through someone's initial fear and hear the real reason behind it. Once we get to that reason, we need the tools to be able to help and to listen. And then we need to ensure that we've spent the time making connections within the healthcare system to ensure that help is meaningful and joined up. Some examples could be ring fencing a number of GP appointments to specific testing sessions, meaning if someone needs to see a GP, we can just make that appointment straight away, or we can empower them to make that appointment straight away. If someone really isn't comfortable accessing a GP, we can accompany them or ensure there's a friendly face to meet them. Even better, if we can have advice or help from a health professional available right there and then, and sort of reducing the number of times someone's past bad experience might outweigh their current better experience. And that actually sometimes the barriers being faced aren't directly to do with heart health or even health at all. And that's another aspect where community organisations like ourselves can really add significant value with that local knowledge and context. So in summary, number 1, the logistics are really important. Think local. Number 2, people do care deeply about their health, even if they're not showing you in that moment. And number 3, people face barriers to living happy, healthy lives, particularly in communities at the sharp end of inequality. And if we want to affect inequalities, we all need to tackle those. And tackling those is about working together. It's about communication, relationships, openness, and building trust. Thanks.